Happy Wednesday, everyone, and welcome back to our Fertility Live Q&A. We're going to be joined tonight by Dr. Kenneth Gelman, so he'll be hopping on here in a few moments to answer all of your questions. I hope everyone's had a wonderful week so far, and I'm excited to kind of jump in and get started as we do mostly every month, pretty much every month. Since the pandemic started, we've been answering questions that you've had, and I always learn something new from you guys and from also all the awesome doctors that we have on here from IVFMD. So we'll be talking about acupuncture. We'll also be talking about IVF support, IUI support, and also natural fertility support as well. So I see a couple people join already. Hello everyone and welcome. And we are also going to talk about supplements, things like that, I think sometimes people do have questions because you want to do everything you can to support your fertility, to help with egg quality, help with circulation, all those things, but we want to make sure that we're not doing things that are detrimental or that might be harmful. So and then also the question is, when do you start those things? So we're going to be answering those questions and more, and hopefully, let's see, Dr. Gelman will be jumping in here soon. I don't see him yet, but I know that you're out there, Dr. Gelman, because I know that we just spoke. So as soon as I see you, I'll go ahead and invite you in. And in the meantime, for those of you who submitted your questions, we're going to be asking, we're going to get to those first, and then we also welcome you guys to type your questions in the comment section as well. There's also a nifty little question mark below. If you guys see that near the comment box, you can submit your question through there, and that way, if it's like a little longer or that sort of thing, we can pop it up there so everybody can see the question, and we'll be able to answer it that way. So I hopefully that will be helpful. And I'm sorry, but I do not see Dr. Gelman yet, so we'll wait for him to join for a few minutes, and then if he's not able to join, we might have to restart this, but we'll wait for a few minutes. We've also have some questions I know that have been submitted for those of you who speak Spanish, so we are going to be answering those as well. Sometimes our Spanish is not the best, but we will try. And we try to we do have Spanish speaking practitioners at our practice and also at IVFMD as well, just in case you're more comfortable also communicating like that. You can also message us anytime as well, through Instagram or through our website. So let's see here. Oops, I have a text, but I'm not able to see it because we're on a live. So let me just see if I can check. Yes, Dr. Gelman, we have started. So he says he's not seeing me, but we are live. So hopefully he'll be. Maybe if Shirley's listening, she can text him, because it's hard for me to do that through my watch to let him know how to join. But we'll also be posting this on our YouTube, hopefully. We've been trying to do that where certain patients have said, well, I'm not really on social media, so I don't want to, not on Instagram or Facebook, but we do post that, and we try to upload them to YouTube so that you can watch it there. So let's see, I'm going to try to message through my watch because I can't switch over to my phone yet, but I'm going to try to write it. This little watch has a way you can just like scribble stuff on. So let's see if that worked. Okay, we'll try. And so if any of you are joining now that want to, like I said, have any questions about your upcoming cycle, transfer, IUI cycle, any of that, definitely save your questions or type them in and we'll be able to answer them for you. So let's see if we can wait for him to hop on in. Hello, Shirley's here too. Yay. I think Chelsea, hey, how are you? Let's see. We might be, okay, he's messaging me guys through the watch, so let's see if we can get him on. And so while we wait, if you guys can, let me know where you are in your journey, if you're comfortable sharing that, if you are willing to share that. If you're trying, if you're waiting, kind of in the waiting stage, you can type it in the comments if you want to, and if not, I totally understand if you don't want to do that. He says he's not seeing me starting the live, but I'm live. Okay, so I wonder if I can invite him. So I'm gonna try to send him a little invite. Let me see. Probably not no, because he's not. Oh, I see him now. Yay, I think we got it solved. I'm pretty sure. Let's see. Okay. I just invited. There he is. All right, cool.
Hey.
What was wrong?
Yay!
Well, how's everything?
Good. How you doing?
Good. Welcome, Dr. Gelman. This is Dr. Kenneth Gelman from IVFMD is joining us today, and everybody's kind of trickling in on a Wednesday, hot summer day here. So you guys are welcome to ask your questions in the chat, or definitely type it in the question mark section, and we'll be able to pop it up there. So welcome, everybody. My name is Dr. Farah Duro. I'm a reproductive acupuncturist. I have a practice called Florida Complete Wellness, and we're in Hialeah Gardens. And we work with patients from IVFMD. We've been working with you guys for probably over 15 years, long time, and Dr. Gelman as well, and have just seen really wonderful results. This month, I think we had, I don't know how many pregnancies, there were lots, for your patients. And
there were a lot this month.
A lot, yeah. And, we have also, we're getting questions already, great. We have a lot of information to share because Dr. Gelman's been practicing for at least how many years? More than
Don't ask.
20 years or more than that. So he's seen pretty much everything. So please don't be shy. You can pick our brains, and we're happy to be here to help you guys tonight. So we'll take the first question here about natural killer cells, because it's an important question. Someone's asking if you can tell them if natural killer cells are rare. They're saying mine are high and have had 3 miscarriages and not sure what to do. I'm so sorry to hear that, first of all.
Yeah, well, it's always a big debate whether that really is playing a role or not. Nobody knows for anything definitively sure that just because you've had, unfortunately 3 miscarriages and your killer cells are high, that's the cause of it. But if you've had a complete workup and, you've had PGT on your embryos, I mean, to the best of our ability, those are chromosomally normal ones you're implanting. You've had, your uterus looked at, that there's no, problems with polyps or fibroids or, endometritis or, Asherman's, or something with the lining. You don't have a clotting problem. So all the tests for thrombophilias are negative, and, and the only things up, and maybe you have anti-thyroid antibodies. That's a clue that maybe you have autoimmune disease, or you have lupus, or you have some kind of elevated ANA. Maybe there is some kind of subclinical autoimmunity going on there. But that I think that has to really kind of be looked at in the context of everything else. And, I don't think it would be the first thing we would look for, but, in this situation, maybe it's worth treating you. Now, the question is, what do you need? Depends, most people would probably give you intralipids, I would think, because it's pretty cheap and easy and safe. But, some people, where we really think this is immunologic, and there are some people out there where there definitely are immunologic losses. They require, more heavy duty things like IVIG and, prednisone, things like that, and, maybe even blood thinners. So it depends on the situation and what other constellation maybe of antibodies or other problems are going on there to decide what type of immune therapy you might need. So, that really should be discussed with your practitioner, but, that's got to be, he's got to have an expertise in that too.
And sometimes we see coexisting natural killer cell elevation with blood clotting disorders too. So I think that's important to get that checked as well and make
Well,
sure
that's
there's
what I was
not.
saying is that, the thrombophilia is the panel that
Mhm.
checks that, so that really should be checked. And most OBGYNs would check that right away. They're pretty familiar with that. So a lot of times the patient comes to us, they've already had the clotting or the thrombophilia panels done, and it's all negative, and you know but the natural killer cells, the important thing also to know is that sometimes if other doctors are sending out the natural killer cells, if they're looking for that kind of thing, it depends on where that lab gets sent.
Yeah.
You got to really be very careful, because if it gets sent to Quest, it's useless.
Really? Okay.
Yeah, they're not real good with that. I mean, it has to go to immunology labs that
Okay.
specialize in this kind of thing. So, and a lot of times it doesn't get covered by the insurance, which is a little bit of a tough thing to, stomach sometimes, because you have to repeat those a few times, and they're not cheap.
And the treatment would be different based on the amount, the
Well, it depends.
level, I
Again,
guess. Or,
depends on the scenario here.
okay.
Depends on what we think really is going on here. And if we really think this is an autoimmune problem, sometimes you may want to go with the big guns.
Mm-hmm.
But sometimes the NK, the natural killer cell test, one of the tests you can get is to get an idea how well you suppress, with the different therapies. And, NK activity gives you the ability to sort of get an idea that, hey, you're going to suppress nicely with intralipids or IVIG or whatever it may be. So you have an idea that maybe things are going to work out pretty well. But, there's no guarantee that just because we treat you with all this, that implantation failure may or may occur, obviously, but it may not.
No.
So there are going to be some mysteries out there that we're going to not be able to necessarily figure out.
Yeah, it's so frustrating when you have perfect embryo and then, and it
Yes.
miscarriage, we
Oh,
hate
yes.
that. Everyone hates that. Oh,
Yeah. Well, embryos are embryos. I mean, when you look at the embryo, it's the genetics, really. You don't know anything else about the embryo. And when we had Inyan here a few weeks ago, our chief embryologist, she made clear that it's not, the embryo has to do a lot of other things once it gets in there. It
yeah.
has to have the metabolic machinery and the metabolics, as it's called, or, to promote itself
Mm-hmm.
and grow. Sometimes they don't have that. And, there's no way we're really going to be able to tell that by looking at an embryo in a microscope.
Yes, it's so true. It's the
Yeah.
most frustrating thing I know, and I really hope that that you find a second opinion, perhaps, or after three
Well,
losses. I mean,
well,
that's
I
hard.
think, I think, I think, a lot of that will go back to promoting good quality embryos
Mm-hmm.
is really, what we should be focusing on,
Mm-hmm.
mainly. And I know, some people in our practice, Scott Rosef and, people like that are really very, very, very into, promoting good health in people and avoiding inflammation, and some of our lifestyles consultants are really excellent at
Mm-hmm.
helping people promote exactly the environment that eggs should be in. Because, eggs are tiny little things that are going to mature over a 90-day period in your ovaries. And if you're exposing your ovaries like the rest of your blood vessels to, bad things, smoking and drinking and, bad foods, for example, well, your eggs are going to get exposed to that. So you're going to bring up these eggs that have not been, traveling under the nicest conditions for the last 90 days. And, you want those eggs traveling in first class.
That's nice. It's a nice analogy. I like it. Yeah, very good. And she's basically saying, I've been tested for everything from my OB, and natural killer cells from the biopsy were very high. So I will talk to him about treatment. Thank you for your help. So
Mm-hmm.
very good. We do have a question over here. Um, my goal is one more child. I have PCOS, 38 years old, chronic endometritis, pending results of biopsy to determine specific type. Hysteroscopy failed. 1 PGT tested embryo day 5 and 1 untested day 6 BC embryo. Should I consider another egg retrieval cycle?
Well, that's always good to have. I mean, I would, at 38, I would do it now, because if you get pregnant, you're going to be 39 and, maybe 40 before you come back. And, if you decide you want to have another one, just to have backup on the one untested one there. And by the way, even the one that's untested may not be genetically abnormal. It may be perfectly a fine embryo. Mm-hmm. But if you're going to consider another retrieval, now's the time to do it. But, you're raising some interesting questions here. The endometritis being one. And that's becoming more and more of an important topic, I think, because there are patients out there that are really, really troublesome in terms of this, where we can't get rid of it. And they've had multiple biopsies and things like that. And, we have this nice M-analysis test from Ingenomics, which is a newer kind of biopsy. It's sort of like a culture. It cultures the endometrium and gives you an idea of what the bacteria are in there. It's probably, it's a good idea. Let me tell you that. And, it'll give us, I guess, more targeted antibiotic therapy, and presumably it'll help people more. But we don't typically do these analyses, right away on everybody because they're expensive. They're not covered, So with somebody that's maybe had endometritis and has had a biopsy and, we re-biopsy them to make sure, and they still have this business, I think then they got to get an M-analysis biopsy so we know how to target their treatment. But, these multiple biopsies may be interrupting their endometrium.
Oh, that's true.
Well, you hope that and pray, although I haven't had that situation really, but people can mature their lining and get a thick lining and, things like that. And, actually in the last version, last issue of the Fertility Journal, I think it was in August, I think, they talked about this because they had a debate on lining problems, pro and con, endometrial lining thickness and things like that, which basically, they can't give you an answer either way. It's pro and con, whether your lining should be thick and, or whether it should be a little thinner and, you could still get pregnant, which apparently you still can. But I think the gist of the article says that the endometrium should be certainly over minimum of 7. But there are pregnancies with 6 too. And there's actually been pregnancies with 4 millimeters. So,
okay.
And they also make the point that in IUI cycles, the endometrial lining thickness doesn't matter. So, it's kind of an interesting point. So maybe the lining isn't as important. But, with endometritis, we keep biopsying people and, interrupting down there. So, you got to be a little concerned about that. And they were even talking about some of these people maybe getting, platelet-rich plasma infusions to try to repair the endometrium, in particular like Asherman's phenomenon, where it might be an effective therapy, although there's not enough studies yet.
To the lining, the actual inside of the uterus?
Yeah. You put it in twice but, preparing it and getting it, it's also going to be very expensive. So it's not an accepted option yet. And, I think they got to do more long-term studies on it to really know. But that might be something to look at in these people with a lot of chronic endometritis. But,
okay.
as far as that was a long answer to your question, I guess. But if I were you, I would do another retrieval. I would.
We do have another question that was also here that I want to make sure we get to. I'm 40. My 3rd egg retrieval is this week. Should I refuse transfer day 3? Wait to blasting. Last retrieval got transfer 3rd day and failed.
I would never we don't do any day 3 transfers.
Yeah, she says
we haven't done those in 10 years or more.
I'm 40 and round 3 IVF. I have poor quality eggs. That's what she says.
Well, that's probably why they're doing it. I mean, I understand why they're doing it. But, if they're not making it to day 5, then they're not going to make it, period. So there's no point you know, and don't, you know, I mean, they're trying to, you know, obviously give you a transfer.
Mm-hmm.
You know, I guess that's good in a sense, but, you know, the day 3 embryos are very misleading. You don't know what they mean in terms of, you know, 8 cells. If they're 8 cells, great. You know, that means they're on the right track, but, you know, they have 2 extra days or so to grow, and, you know, it may be an aneuploid embryo. You'd like to know that, I think. So day 5 is what we would do. I wouldn't transfer on day 3.
Yeah, and I was just thinking of an article I read today about in Georgia, your embryo is actually considered a person now because they can actually
Really?
you can take a tax deduction, yes, a state tax deduction, if there's a heartbeat. So I was thinking, this is crazy.
What was that now?
In Georgia, yes, they are considered any, you know, well, not an embryo anymore, fetus, at 6 weeks with a heartbeat.
So it has to have a heartbeat and be 6
yes, it has
weeks.
to have a heartbeat, and you can actually claim your tax deduction. You know.
Oh.
So there was a story, but somebody got pulled over, and she said, "They go, ma'am, you're in the carpool lane." She said, "But what about this? You know, I'm pregnant. Can I please go through?" And I'm in Georgia, and they're considering this baby to be my, you know, a person now because it's like, you know, 3 months pregnant or something like that. And I'm just thinking how many, you know, people are, you know, in different states having these discussions, but especially around IVF. I know that wasn't one of the questions asked, but it's very, you know, interesting to look at that. Depending on what
Wait
you
a minute. What did the cop say to her?
so he was going to give her a ticket because he was going to pull her over and say, like, you're using the carpool lane, shouldn't.
Yeah,
She's
but
like, wait a
you
minute,
won't now, right?
you just said now that I have a person, that this is a person.
That's right. You have a person. You're giving.
Yes,
That's right.
so I'm legally using this carpool lane.
That's pretty sharp of that woman. Yeah.
Yeah, and I don't know, but apparently I don't know if it went to court or who knows, but
Wow.
yeah, I think that might have been Texas. I'm not sure it was Texas or Georgia, but Georgia definitely came out and said, guys, you can do your tax deduction, your state income tax.
That's pretty good. Yeah.
For that, you know. Anyway, depending on where you are. So if you're in Georgia now and you're watching this and you're doing IVF, you know, I don't know what happens if that pregnancy doesn't go through to term, or they don't know that, you know.
Yeah.
So, well, anyway, all these.
Well, I guess you keep your tax deduction or what? Or you got to pay.
I don't know what happens with that. Anyway, so it's kind of interesting. I know it's totally off subject, but you know, thinking of embryos and fetuses. But so, you know, with this, I guess also when you're making decisions about your treatments and that sort of thing, I really do encourage people to get second opinions, especially like when there are places that, you know, only do like one. Maybe they're not going all the way to day 5 and they have no idea like what their embryos are doing. I don't know if that's going to be the best route for a lot of people, especially if it's not working, you know. So if it's not working repeatedly, maybe it's not a bad idea to get just a second opinion, to pick someone's brain and say, what is the best, could there be another route, you know, that, and it's precious time that you might be wasting as well. If you're 40, it's
well,
like
this person, you know, this person is 40 with poor quality eggs. Well, you know, 40, we know well under 50% of your eggs are not going to be good quality at 40, period. But maybe that person needs to be gone over. You know, maybe she's got inflammation. Yeah. Maybe she's got all kinds of stuff that potentially, you know, could be improved over the next 3 months or so. Yeah. And then try another retrieval, but try to take it to blast. Yeah. Or maybe a gentler stimulation, so you just try to get quality.
Yeah. Yeah. And
yeah.
People are still doing day 3 transfers, I guess, so fresh transfers.
Well, we don't do them.
Yeah. So I guess you would have to look at that. What is the success rate for your age group at that clinic doing that procedure? All those questions, because I really think, you know, there's not time to waste. You want to give every single. It matters where you go. It matters who you talk to and who you see, because you can't rewind time. And unfortunately,
right.
So let's see. We have I think. Okay, there is a question about PCOS. How do you know if you have it? Like, what blood work can you do to find out if you have it, other than AMH? Which AMH is not a measurement of PCOS, right? I keep seeing this, and I'm like, I don't think it's diagnostic. It maybe is like maybe.
Well, I think it's one of the tests that they're looking at now as being part and parcel of PCO. You know, it's usually well on. I had a woman the other day she told me I have to receive it. Her AMH is 90. I
Oh,
have
well,
not seen an AMH of 90.
never heard
I've
of that.
seen it. I've seen it in the 40s, 50s, but not 90. That's the highest AMH. But
Super high.
after I looked at her ovaries, I can probably understand why.
How many follicles does she have?
I couldn't count them.
Holy cow! Wow,
I
that's a
mean, I
problem.
mean, her ovaries are just jam packed.
Wow.
So there's
I
no
mean, that's not
question
very
she has.
clear. It's
Huh?
not so clear sometimes, right? It could be like, what do you do when it's
Well,
like 10
I
or?
mean, polycystic ovaries are just one of the criteria
Hmm.
to diagnose PCO. There's some new criteria came out, I think, in 1990 or 2000. I forget the year. But you need 2 of 3 criteria. Polycystic ovaries being one, irregular cycles being one that you have to have, clinical or hormonal evidence of male hormone excess. So you need 2 of 3 criteria, two criteria to meet the diagnosis of PCO. So if you have irregular cycles and polycystic ovaries, you got PCO. If you have clinical or hormonal evidence of male hormone excess and polycystic ovaries, you've got PCO. Weight is not a criteria.
Yeah.
Yeah.
I
But
mean, there's a lot of people with metabolic syndrome too, and it's very close.
metabolic syndrome, yeah, is part of PCO. It's associated with it, but it's not the criteria to diagnose PCO.
It is kind of confusing, I know, a lot of times for that. But because a lot of people have facial hair, they might have that because genetically that's what they have, and so sometimes that gets overdiagnosed. Like
Right, and and even if somebody is metabolically challenged, they have insulin resistance and they're pre-diabetic, their A1C, is 6, and their testosterone is sort of the normal range, whatever, and maybe they have a little weight issue, and maybe they have a low HDL cholesterol with a high triglyceride. They're more like what's called syndrome X, which is a metabolic problem, that you would treat the same as PCO, really, with metformin and, weight loss and special diets and, things like that, statin drugs if they needed, or Lovasa, things like that. But so a lot of times these people may not have the diagnosis of PCO, but they could be treated in the same way.
It's really fun. Yeah, so that's it's important to I think also treat those things. I know a lot of people go on birth control and then come off of it and then have difficulty conceiving. So because they didn't know they had PCOS sometimes because they're just given it for irregular cycles or whatever it is. But they're not addressing also the the insulin resistance sometimes or the underlying issues there. And that's where we see people running into problems, a lot of times when they're like, well, I thought it'd be easy. I thought I could just come off of birth control and then boom. And sometimes it is, and a lot of times it's not. So, and we see patients, I know you've seen them, that have been on birth control for like 20 years sometimes. So it's like, it's really hard to see that. You don't feel it. You don't feel like, that you're inflamed or you have all these cardiovascular risks going on. But it could be damaging to egg quality too, as your testosterone's high and all those things. So,
No question.
Yeah.
So can the lipids being abnormal be a problem?
Right. And so I think we talked about particle sizes, like checking your LDL particle sizes on the.
Yeah, last time we talked about that. That's the Quest has a winner of a test there.
Yeah.
Where you can really assess somebody's metabolic risk even more, by particle sizes and things like that to sort of get a better idea, not only for atherosclerosis, the cardiologists are looking at these things, but, when you have that kind of problem, you're affecting your eggs too. So it's good to do. And, it's good to, especially in the men, as I talked about this last time, I think the men need that because the men get neglected a lot in this field. And we're ones that really, men seem to come to because, they're anxious to get pregnant. Maybe they want to check their sperm. They all want to know what their sperm is. At the same time, we slip in these lipid tests on them and things like that. And then we start counseling them. So we're in a position to really do that. Whereas the primary care physician, may or may not be because men don't go to doctors that often.
Yeah, for sure. And I've just been noticing a lot of high particle numbers with LDL and with the Quest. But you're like, oh, okay, what's that about? And then a lot of our patients have the MTHF mutation. So apparently that's one of the factors too that could cause that elevation. So if you're in that boat where you're like, I'm a heterozygous carrier for MTHF, you have issues with metabolizing folate and B6 and B12, and you know, you have high cholesterol, like, or you have the LDL that's off, that actually could be causing it. And a lot of people blame themselves, like, oh, my diet and all that, but I'm eating so good, how come my cholesterol is so high, and all those things. Sometimes it's genetic, you know, as well, and that's part of it. And sometimes just treating that, like the Methanex and all those things, like that's really important for that. So we always recommend going to nutritionists and also looking into your genes, because so many of our patients have that. So many have high particle numbers. It's like,
it's really important. I think we're in a unique position to pick that up. Mm-hmm. I think as much or more so than primary care doctors, again, because of what we do, and, you know, men, you know, being sort of almost a captive audience in our practice. Yeah, so you know, there's not enough time, I don't think, spent with them, but I think we should counsel them more about that kind of thing, in addition to the women, obviously. But
men, I find, are more concerned with their testosterone. Like, is the testosterone?
Of course, you know, men, you know, care about certain things, you know, and, you know, I mean, they'll complain, you know, or actually a lot of them won't even complain. Some of them have erectile dysfunction, things like that, and they won't even talk about that as much. You have to pull that out of them. And, you know, some may be tied to these lipids. You know, if we improve lipids and things like that, we improve blood flow.
And statins are not recommended during fertility either. So they've got kind of that double.
I don't know anything of whether some of these injectable, like Repatha, which are these special drugs that you can inject every 2 weeks, and actually they have one now. You inject it every 6 months, and it drops your LDL dramatically, because it regulates the LDL receptors in the liver, and it has a dramatic effect. It's a fantastic drug with no side effects.
Oh, okay, that's
nothing.
Yeah. We do have some questions submitted before, so I really want to get to those because I don't want to leave them out. And
there's a lot of acupuncture questions I saw.
There's a lot of acupuncture. So I know we talked sometimes about the protocol for acupuncture. If you're getting acupuncture during a transfer, like, or before a transfer, like, kind of what it is. There's not like a set in stone protocol. There's research studies that we use to, you know, select our points and we look at what's really working the best. And most of the studies look at the day of transfer, and then some of them look at 2 times a week, the 6-week period prior to the transfer. So that's kind of what we focus on, like that. Those results have been a little better than the day of. So we try to encourage that if possible, at least 6 weeks prior, to try to step it up a little bit if you can, you know, and try to do twice a week. Acupuncture, we do test blood cortisol levels in our patients. So we see that if they're really high, we need to probably do a little bit more. And, you know, those patients, hopefully we're seeing them before they get to the transfer, because going to a transfer in and of itself could be a little stressful as well. So we try to get that time for the treatment to work. But if you don't have much time and that's all you can do, the minimal, I would try to do the acupuncture either the day before the transfer or the day of. And if you are able to do it on site. And then, you know, I do think the post-treatment, like post-transfer part is very important. A lot of people are very anxious, waiting for those results. They are testing several times, even though you guys tell them not to test. Everyone tests. They're testing, they're checking. Everything is, they're feeling cramping. They're not sure if that's right. So, you know, that's a lot of pressure. It's a lot of anxiety. So we try to work on those points to help with that. And some of it is a lot of times mental. A lot of acupuncture is actually about working with stress, alleviating stress relief, and also helping with circulation. So that's our protocol. Is really, we're there for you if you want us to be there for you for your transfer. And if you are not able to do that, we do, some clinics do not have acupuncture at the transfer, so we do that the day before. But I know your patients do have acupuncture on site, like they are able to do that. So myself or my colleague, Dr. Aracena, is there with our patients and your patients, and we do a pre and a post transfer treatment. So there's one right before and there's one right after, as far as 2 different treatments that have different purposes, different points. so that's for that day. And then there,
Yeah,
you know, there's,
just one quick point there. Actually, the Fertility Journal this month actually mentioned, hasn't mentioned acupuncture in a while, but they mentioned it,
Mhm.
particularly electroacupuncture,
Yeah, that's my favorite.
being
Okay.
very, very useful potentially in thin endometrium.
I love electron.
So, and one of the things we could do, I guess, is to sort of monitor, the uterine artery resistive index, the blood flow. Actually, you see their resistive indexes drop dramatically with acupuncture. So, which means the
Yeah.
blood flow to the uterine artery and the lining is much better because you have lower resistance. Just like old physics, less
Yeah.
resistance to the blood flow, so the blood flow's going in there. It's like lowering your blood pressure.
You can do that with Doppler, or how do you
We
normally?
can. I don't know if that machine. I don't know if they calibrated it
Yeah.
on our machine specifically. I think I have to have a rep come in and do that, but you can do it.
I've kind of done my own informal studies of that because we don't have ultrasound in our office. But I've been to enough births at hospitals. We used to do acupuncture during labor at Memorial Miramar many years ago, and we would do electroacupuncture while the patient was hooked up to the monitor, and we would see the contractions increasing as we were doing the electroacupuncture to mostly the sacrum, those points that are there, and connected to the areas for uterine contractions. We want to promote it at that point. This is a totally different treatment. Obviously, we're trying to do the opposite when we're doing acupuncture during the transfer. But when you're trying to promote uterine blood flow, those points are actually very good. So we would see the contractions getting closer together during the electroacupuncture, and then when we would stop it, they would get further apart. So it was it was interesting. These patients are trying to avoid C-sections, so and I think that was kind of validating to us to say, okay, but definitely it's working, even though these patients are also under anesthesia, so they had epidurals, so they didn't even
Yeah,
feel it. We were
yeah.
cranking it up too. We could crank it up pretty high, but I think that it would be great to be able to measure that with patients,
We
and
could.
have them
We
feedback.
could. I mean, to show the patient that the treatment's working.
Yeah,
It's maybe a good idea. So the next time I see the rep, I'll have them um, put that in our machine. They have to put a special update in there, I think, to
yeah,
do
that would
that.
be excellent. We're always asking, so what's your lining? How many follicles you have?
Well,
Um,
the other thing that tells us that it's working, I had a patient, I think it was yesterday, day before yesterday. One of the patients seeing you, she says, I go to Dr. Duro and I'm falling asleep as soon
yeah,
as I get the acupuncture. I never did before, but I'm falling asleep now. They
yeah.
love it.
That's awesome. I'm so glad that we can put people to
You
sleep. I
know,
love that.
they putting them right to sleep.
That's
You know,
there's
who,
actually
who wouldn't love that?
I know, like they use it for anesthesia. Actually, when I was in China, that's what they were doing that for certain procedures. Like I mean, dental procedures, which is pretty cool. But I think if you can, it's very multifaceted. There's many things you can do with it, and especially if there's a lining. Well, who doesn't want to promote more blood flow? I think that's really important for the medications to work their best and for the patients to have good outcomes. So we try to do everything we can for that, and the fight or flight response I think is important too. Like we're just wired that way. If we're trying to run from something, our body's
Yeah,
going to shut off and not say, well, it's not really conductive right now to get pregnant. We need to survive, we need to function, we need to pump that blood to the heart and the lungs and the special organs, but not really to the uterus so much. It's not very high priority. So we want to flip that switch and hopefully get the same thing that yoga does, many meditation practices where you're in the parasympathetic mode rather than the fight or flight mode,
yeah,
for most of the day, hopefully.
yeah,
so,
yeah,
um, so that's one
yeah,
of the
yeah.
goals.
That in yoga it comes from breathing.
Yeah, definitely. And we do meditations during acupuncture. So there's actually a study that they actually tested the brain cells of the people who were meditating, and they were 10 years younger than the people that
Oh,
were,
for sure, I believe
yeah.
that.
So I think if we have that time, a lot of people say, I don't really have time to meditate, but that might be the only time you have, like that whole week, to just get that in. So it's a 30-minute meditation we do with the needles in. And it's most people, if you fall asleep during it, it's okay, because I think subconsciously you're still kind of getting that, the benefit to it. But after you do that a few times, your brain actually just goes into that mode. So at the transfer, we're playing that same meditation that we do during acupuncture, and they're like, "Oh yeah, I know that." So, and like I think one of our patients was asleep, right? When you're right before her transfer, she was completely out. But
Yes.
yeah,
Recently.
recently, yeah. So
Yeah.
like, oh, I gotta wake you up. Your transfer's going. But I think your brain just like it'll go to that good place. We hope so. The other question was, is 2 times before the transfer enough time for acupuncture to do anything? And it depends on you. Everyone's different. I think that it's better than nothing for sure. And I think it says, do you recommend acupuncture session the day before extraction and transfer? So yeah, the day before the retrieval, we definitely do acupuncture. A lot of times it's with electroacupuncture face down, because already you're very sensitive. Your estrogen is like through the roof, and you might have many follicles. You don't even really want to be touched on your abdomen a lot of times. So, but we still need to work promoting blood flow, helping with that. So we're going to do very gentle back treatment, usually with electroacupuncture in our practice. So, and we try to get that in the day before the retrieval if possible. So, yeah, and another question about it was, what about there's someone who had a transfer who failed the transfer, and should they try acupuncture for next time, and when should I begin? So, I mean, what do you recommend? Like, if you have a patient maybe who, hasn't done acupuncture but didn't have success with a transfer, like, what would you recommend usually?
Well, everything we've been saying, all along. I mean, it's going to be we got to look at why that person failed.
Mm-hmm.
Was it a poor quality embryo? Was it a great quality embryo and we don't know why it failed? And, so, as part of the whole process of looking into what to do for that person, I would add acupuncture for sure. Because if I thought, obviously if you weren't stressed before, you're going to be stressed now. You got one less embryo, it didn't work. Maybe we really thought it was going to work and it didn't.
Mm-hmm.
That's kind of a shock. And, it's not an easy thing to sit in front of a patient and try to explain to them what could potentially be going wrong here. Or if it's the second time where it didn't work, it's even worse.
Yeah.
So I think acupuncture would be very important as part of this. The longer the better. 6 weeks minimum, if we can, in addition to the other things we'll probably institute.
Mm-hmm.
Again, depending on what we think was one of the things that we think went wrong there.
I mean, I would love if everyone 100% could have, a positive pregnancy test. That's what we always want. But we know that that's not always the case. And
it's not the case. And you would think that it is, because things have gotten so much better with IVF.
Yeah.
And you would think that, because the doctor is working on this and it's very scientific. You've got these embryologists working diligently in the lab and putting eggs and sperm together and biopsying them and getting genetic studies and, all these kinds of things. And, you would think that we would already have this tweaked to 100%.
Mm-hmm.
It's not.
Yeah.
And while we try to approach that, we probably will never reach that, I would think.
Yeah, I mean, as humans, we're not as efficient as a lot of species.
No.
For reproductively, who knows what the future holds? Apparently,
Yep.
There's Mars and there's cloning, all kind of things. But we just can do our best that we can do right now in this moment, and that's really trying to incorporate everything we have and helping our patients as much as we can. So for this patient whose transfer failed, I would say, try to get a good team around you, have good support, and
Right.
we're always here for you too if you ever
Yeah.
need us.
I mean, your goal is to make this work. Your goal is not to do this 3 or 4 times. Your goal, this is a very time-consuming, very stressful, very financially taxing process. You don't want to be doing this 3 or 4 times. You want it to work, hopefully the first time, maybe the second, That's it. So do things that we know are really going to help you.
And I know that you guys really overturn every stone. Like, I don't think that there's anything that's left undone a lot of times when a
We
patient
do,
goes through a
we
transplant.
do, we,
Like,
we do, we do, and and
so,
I had this conversation the other day too about endometritis, for example. How we are diligently looking for that, and we're opening these can of worms in people that are totally asymptomatic, a lot of them,
yeah.
and we're finding these things, and we're going after it, hook, line, and sinker, because we don't want to fail.
Yeah. I've seen that throughout the years, and I don't think a lot of clinics do that. They don't really go that extra mile a lot of times.
Well, they will if they hopefully will after people fail at least one, maybe two times, maybe. I don't know.
Well, from the get-go, from the beginning, that's when it should
I don't know if
happen.
they do it. I don't know if they do that. I don't think so.
Yeah, that's insane. I think a lot of people say, "Well, why wasn't this done? Why can't I have done this in the very beginning?" So would have avoided a lot of this stuff, and so that's the hard.
Well, that's the point. That's the point. You don't want to go back and find that and say, "Oh, this could have been it."
Yeah.
And a lot of times it's chronic endometritis, which means it's been there.
He's been there a long time. Yeah. So frustrating. So definitely, I have a question about a varicocele. So what do you recommend if someone has varicocele? And the husband has this is in Spanish, so they have low. The husband has varicocele, and they have the female has low ovarian reserve. So what about IVF? Would that be something recommended?
Yes, definitely. That I would definitely recommend that. As far as varicocele surgery, well, not particularly. Maybe not in this situation. I would recommend it because while it may definitely help things, it may not for sure, and it may take you a long time to find out if it does help, or it can make things worse, or things may not change at all, and you're going to end up spending quite a bit of money on varicocele surgery, and your wife doesn't have the time for you to wait for sperm to improve, especially if she has DOR, diminished ovarian reserve,
right?
or if she's older.
It might not work, right? That surgery, unfortunately. So
that's correct. So you don't want to wait. So I would go right to IVF with ICSI, and hopefully the best. Now there was an article also in this month, interesting, that patients' age, their BMI, and sperm parameters don't contribute necessarily to male aneuploidy risk.
Okay.
We know that males can contribute, or part of aneuploidy or in abnormal embryos. It's not just females, but there's no correlation necessarily between that happening from a male side and sperm parameters. It's an interesting article.
Okay.
So, it suggests that maybe, while obese men might have a higher incidence of abnormal sperm and sperm, decondensation, their sperm is disrupted and all this stuff. Well, it's nice to obviously get them healthy, but this article seems to say that it may not necessarily correlate with an abnormal embryo.
Okay. Well, that's good news, right?
Well, I think so. I think for this person, it might be good news.
So that's
because even with a varicocele, not every single sperm that's ejaculated is abnormal. The embryologists are and what this says is the embryologists are probably pretty good at selecting the normal appearing sperm out of there. And, despite having really terrible sperm in the ejaculate, the way it's looked at, it may not necessarily mean anything.
The follow-up question to that she says was, would you recommend IVF or IUI? Which definitely
IVF. Don't waste time with IUI.
Yeah. And we have a question that wow, where'd it go? I put it in. Oh, here it was. I think it faded. Do you guys see that question that I popped in?
Which one?
Oh, there it is.
What's a good egg?
It went away now. Oh, there it is. Okay, what is a good egg retrieval response for a 32-year-old patient in numbers 6 eggs, 15 eggs? Like, what would you expect?
Well, the normal or the average is 8 to 15. But if you ended up with 6 eggs, and 5 fertilized, and all 5 or 4 made it to blast and they were excellent quality, well, that's a really good cycle, isn't it? Many times we get people, in 32 years old, 19, 20 eggs retrieved, maybe 14 or 15 fertilized, and they end up with 2 embryos or 3 embryos, or
Mm-hmm.
so the numbers drop off dramatically.
Okay.
So I wouldn't necessarily get hung up with the numbers. You got to look at the end quality, the end product.
Quality, not quantity.
Quality, exactly. Now, anytime you even get one normal embryo that's cryopreserved, that's a major victory, even though you'd want more than that. But still, from cycle to cycle, a 32-year-old, one cycle may not be great, but you may end up with good quality embryos anyway. Or, one cycle you may not do as well. And you may end up with a lot of eggs and a lot of, fertilizations and, no blastocysts, or 1 or 2.
Mm-hmm. And there's a question about talking about follicles. What type of daily follicle growth is typical during stems? I guess, is it a millimeter they grow every day, or how much are you expecting?
1 to 2 millimeters or so.
And the estrogen correlates with the sizes of the follicles?
It should, we should roughly have an idea by the end, of how many follicles, what your estrogen should be based on what we think how many follicles are there. But, it's hard to estimate sometimes, especially in PCO patients, because their estrogens get really high, and, they got a lot of little eggs there, and, a lot of them are immature, but contributing to that estrogen level. So sometimes it's rather hard to estimate exactly how many mature eggs you will have. But in somebody that's non-PCO, it generally does correlate pretty well.
Yes. And then what is the best thing to do to improve egg quality? That's the other follow-up question they had.
Well, that's what we've been discussing. I think healthy diet is the key. And checking all your levels and antioxidants and things like that, and making sure you don't have any inflammation in your body. Maybe seeing our lifestyles consultants, and having all your panels done, and making sure your diet is pristine. Get rid of plastics in your house. Don't microwave in plastic. Use BPA-free products. Things like that. Because you have those 90 days or so to really, really improve your environment there. Maybe you need some extra supplements too that we can give you. So these are the things we should do.
There was a question about taking chlorophyll prior. I've had a few questions about chlorophyll, and I think taking that prior to stimulation, I guess. Or I'm not sure if they. I'm not sure if they said transfer or stimulation. I'm trying to see what it was. Do you recommend taking chlorophyll? Oh, period. Okay, my acupuncturist recommended it. We have we've used for many years a little compound that's a greens powder, and it has some spirulina, some chlorophyll. It has plant-based protein, and it also has antioxidants and all fruits and vegetables pretty much. And we've done this many years because it's very difficult to get eat the rainbow of fruits and veggies every day. You might go the whole day and not have anything green whatsoever. So this actually is a little cheat, but it's a way you can do that. There is some research about chlorophyll and spirulina helping with all kinds of things.
What's the name of that product?
Greens First. That's the one that we use. Yeah, and it's nice. It comes in a chocolate flavor, a minty flavor.
Does it taste good?
It tastes so good. I actually found out about it because I was at a conference and I was falling asleep because it was a long conference, and there was a little table in the exhibitor area, and they had little shots of this, and I said, oh, if it's wheatgrass, I don't know. I don't like the taste of wheatgrass. I feel like I'm drinking a lawn, and so but this was actually really good. It didn't taste at all like wheatgrass, even though it has a little bit in it. It's very minty, and it tastes like green tea kind of. So that's kind of what we use with our patients, and we try to.
Do you have to mix it, or it comes like
you can mix it with cold water, or you can just throw it in a protein shake. So a lot of times we'll use like the collagen bone broth sort of powder with protein powder and the Greens First.
Where do you get it?
We always have it at our office, but you can also find it, I believe, online. I'm not sure if Amazon. I don't trust Amazon because this has probiotics in it, and I don't know how long these things have been sitting in warehouses. I think I sent you some supplements that we were talking about, and I noticed it was different ingredients on Amazon that it actually
Yes,
That would,
yes,
that
yes.
would, and it's
The
weird.
NAC, the NAC
Exactly.
stuff. Yeah,
Yeah, it looked like it was
yeah,
exactly from that company. I said, this is why I never recommend any supplements on Amazon. I'm really sorry, but I don't understand. There's a lot of copycats, that sort of thing. So
yeah,
try to get it directly from the distributor where they
yeah.
actually guarantee freshness. We have our patients refrigerate it. So, but there's different variations. That's just the one that we like. But yeah, it can be helpful, I think, for at any time we consider all the toxins in our environment and what our bodies go through every day. If we can have a chance to get more antioxidants into our system,
No, no question.
that's a bad idea.
No question. No question.
So,
Absolutely.
so definitely. And one other question about laser acupuncture: is it better than regular acupuncture? It's different. It's just not better. It's just different. So we use both. But there's some research about laser acupuncture. There's a IVF center, I think, in Connecticut. They do laser acupuncture before the transfer. It can be helpful. There's some theory about it exciting the mitochondria and the cells and that sort of thing. I think we typically will use that kind of sparingly because there's more evidence of electroacupuncture and actually traditional acupuncture than there is of laser. Not that it's bad or good. It's just that we tend to go with kind of the tried and true version, and we see that it's actually going to be a little different effect. So laser acupuncture is usually just a few minutes of treatment. It's not that relaxing. You don't really feel any different as far as endorphins kicking in and all those things. So it might be what I like to use it for trigger points. If someone has a really bad, like we had someone the other day with a huge trigger point right in their trap, it's super hard to get to. It's very deep and it's hard to get to with the needle. You can actually use laser and you can kind of feel it start to relax a little bit. So I like that. But yeah, there are some practices that might, use that a little more. We like LED light. I think that's really nice. There's cool research about that and egg quality. So a lot of patients have been asking about that. And they are studying that because that definitely is the time to do it is when, oh yeah, see, somebody just asked. So light therapy, yep. So red LED light. You can actually, it's definitely more readily available now. You can actually find these devices and you can try to do it. It's relaxing. It's 20 minutes treatments. You can they actually have LED lights you can use over the abdomen. It's super relaxing. We use it for microneedling, acupuncture, pain relief, many things. But so there's different options out there, and there's research being done on that. So I think that's really very safe and something that is very gentle. So I think that was all of our pre-submitted questions, and we're almost at the end. So we have I think completed all of our. We'll get to the very last question here. Our questions here. How long does it take for the endometrium to heal after biopsy? Is there anything I can do to help before transfer? I have had 6 biopsies over the past 3 years.
Oh, wow.
Oh.
Yeah, that's kind of goes back to what we were talking about before. Is that endometrium healing properly? But obviously, it's going to take several weeks for the endometrium to heal. And obviously, you got to make sure you don't still have any, residual infection in there. But, you're never going to do a transfer unless you've had, obviously, a full period from after those biopsies and you built up a whole brand new endometrium that hopefully looks, satisfactory and looks receptive, etc. So, interestingly, when we talked about the receptive endometrium in the articles from Fertility and Sterility this month, you would think that they would have addressed whether they thought the ERA test was valuable or not in this setting, of an endometrium. It wasn't. I didn't see one mention of that, whether that test was useful to them in regards to somebody who's had, a thin endometrium or whatever it may be. Only, anecdotally or in a couple of patients I've had, I found it to be useful. So, but this patient, has had a lot of biopsies, and maybe, PRP would be something you would look at, platelet-rich plasma, make sure that endometrium was well healed. And the way they did it in California was a study out there. They infused it on day 10 of her stim, and then on the day that she started progesterone. And apparently they had a higher implantation rate.
Have you guys considered offering that or not?
Well, I don't know. I think they've done some of it in Miami, and it didn't really do much. But we don't. I think it's cumbersome to prepare,
Mm-hmm.
and it's not cheap. So we have to look into it. I think as more and more maybe information comes out about it, maybe we'll do it. But this person maybe should think about it. Had a lot of biopsies.
Yeah. And do you worry about scar tissue at all, or is that a
Well,
factor?
that's the point, or an Asherman's or something like that,
Yeah.
where or you're rubbing out, you biopsy the endometrium so much, you're taking away what's called the basalis layer. You don't have enough normal cells there to respond to estrogen and build up. So I don't know whether she's going to develop a thin endometrium or not. I guess they got to see.
Okay. Well, we started a few minutes late, so we have a few more minutes to squeeze a little.
But I would do an ERA test on that person, because I think, in the few that I've done that in where I've been iffy about their lining, they've gotten pregnant.
Mm-hmm. Yeah. It's not fun to go through it, I know, but it's
No, I mean, we don't have any better tests. I remember saying this the other day to a patient. We don't have any better tests to tell you whether you got things going on in there or not.
Yeah,
That would be
we need to invent
great,
something. Saliva
because
test.
it's the worst thing the doctor has to do.
Mm.
Horrible.
There was something like saliva test for endometriosis that was trying to come out. I don't know if
Well, that was endometriosis. This
Right.
is not. This has.
That's what I'm saying. Like, could there be an endometritis saliva test? That would be nice. I mean,
Maybe.
before it was like laparoscopy
Well,
was the only diagnosis.
maybe I don't know. Maybe something in the menstrual fluid. I don't know.
Yeah. I mean, we have to get out of the dark ages. I think sometimes with women's health, it's like it'd be nice to have some other testing, but
Yeah, it would be.
you have to work with what we have for sure. So,
It would be.
so I think we got to everybody, guys. You've asked some awesome questions tonight, and
Yeah, a lot of good ones.
yeah. Oh, I think we had. Oh wait, we had one more. Yes, I don't want to miss this. Age 31, PCOS, AMH8. First time doing IVF, chances of successful pregnancy.
Well, I think it should be good. I mean, you sound like a good candidate for it. You should do well. You might hyperstimulate a little bit, when they stimulate you. So just, be a little cautious about that and make sure you follow their directions. But, you got to have to get your estrogen up there and, to mature your eggs. And at your age, we should get mature eggs. We'll probably get plenty of immature ones too. But, on paper, your egg quality should be good. You should do well. And you should have, a high pregnancy rate, as high as they're going to quote it there. Hopefully 60%.
Yes, for sure. We wish you the best of luck with that.
Yeah.
And you're the best, Dr. Gelman and Dr. Duro. I believe with your help, you'll be successful. Yay!
Yeah.
Awesome. I'm so glad. And if you need to reach out, you can also reach out to you with a virtual visit still, right?
Anytime. Yeah, we do a lot of them. They're great. They're just like doing this. And, I think this, is fun, especially fun for you and I. We love doing these things.
Yeah, I know. I just like picking your brain, and everybody else does too. So it's really fun.
What's that?
We like picking your brain.
Well, not just mine. I like hearing what you have to say.
No.
I mean, I like hearing, all the acupuncture questions. So, that's really, really very, very important. I got to stress how important acupuncture is. It really, really is. I mean, the patients are so different when they start and when they come in. Because, I see them, every couple of months or, whatever it may be. And they're so different. They feel so much better.
Yeah.
Every one of them says it, by far.
Oh, I'm glad.
So,
hear a
you
lot of,
you should give yourself a pat on the back too.
Oh, thank you. I hear from them saying, "Oh, my husband says that I should come in because I'm better to be around during this procedure."
Yeah, the men should do it too. Honestly, they're gonna only benefit from it.
Mm-hmm. Yeah, I know it's so hard to get you guys in, but it would be important. So, if you're ever, thank you.
It would.
It
would.
I think it would be great. We do have on Saturdays. We do have a lot of couples come in together. I think it's really
cool. That's the way to do it.
Mm-hmm. Yeah. So, well, awesome. Thank you guys so much. Thank you, Dr. Gelman. And,
my pleasure.
Have a great night. Have a great
You
rest of your week,
too.
everybody. We'll
You
see you
too. Enjoy
soon.
the rest of your summer, everybody. We'll see you next month.
Bye.
Bye-bye.